All right, good afternoon, everyone. For who's watching this recording, if you'd please go ahead and scan the QR code for attendance. Just as a background, this is really important because we have to keep attendance and just have on file how useful this is being for the students, so we can continue having SI and things like that. Alrighty, and I'll show it at the end too. So if you didn't get it, that's okay. Alrighty, we're going over normal intrapartum. That's what it's called now. All right, so we have a few key points for the experience. In labor, we have two clients, the mom and the baby. So now we're thinking about two different heart rates, the experience for both of their safety as well. We have the physiological safety, so airway, breathing, circulation. We have psychological safety, so emotions that our mom could be feeling during delivery and as she becomes a mother. Also how she feels about becoming a mother. And we have their maternal history and their cultural considerations. All right, so we already have covered a little bit of this, but now it's kind of getting into a little more. Methods of childbirth preparation. We have Lamaze, Kitzinger, Bradley, hypnobirthing. And then whenever it comes to the conditioning, we are looking at exercise and positions that strengthen the abdominal muscles for the expulsive phases of labor. You can do this by tilting, pelvic rock, Kegel exercises, and squatting. Next, we have the Mick Roberts position, flexing the mother's legs, thighs between towards her shoulders while she is lying on her back to help stretch her hamstring muscles. This is needed for the second stage of labor. Going into relaxation techniques, this is all about allowing our mom to conserve energy for the uterine muscles to work properly, making it safe for both her and the baby. And then breathing techniques, helping keep the mother and unborn baby adequately oxygenated, helping the mother relax and focus her attention appropriately. Ways to prepare for childbirth, kind of really going into the stuff we've all talked about in first exam: proper prenatal care, nutrition, appointments, screenings, and immunizations, prenatal education classes, genetic counseling, especially for our high-risk moms, and to identify if any misconception about the birthing process are present. Kind of what you'll always do in your questions. Our role as the nurse is to address them in a non-judgmental, caring manner, and to provide the support and info they need to make the decision that best fits their situation and comfort. All right, so this is very important, guys. We do have the 4 P's of labor, okay? The first is going to be passageway, the birth passage, size and the type of pelvis, cervical dilation, effacement. That all goes inside with passageway. We have the passenger, our baby. We're going to talk about this more, but we have things like the head, attitude, presentation, position, and placenta. And then, of course, our powers, primary forces of labor. And then the fourth, we have psych and the psychosocial considerations. All right, starting off with passageway, we have pelvimetry, the assessment of the adequate size and shape of the pelvis and how favorable it is for a vaginal delivery. So we're looking at the size, the type. Gynecoid is the most favorable. I don't think she would, for your exam, test you necessarily over that, but it's very important to know which type of the pelvis is adequate for birth, for vaginal birth. Next is the cervix. We also can call this the neck of the uterus. We have these words here, and these are very important. Effacement, thinning and shortening of the cervix from 0 to 100%. 100% is paper thin. So, if you have a question and they're talking about she's only 10% effaced, what would that be like? Okay, next is dilation, opening of the cervix from 1 to 10 centimeters, how open it is. Oh, I actually have something to show on the screen. Let me go ahead and pause the recording. Alrighty, I actually have, let me stop sharing. I have our dilation chart. So kind of hard to see. And I'm pretty sure she'll bring you this to class. Something like this so you can kind of get a feel. But, you know, if we start off going all the way to 10 centimeters and everyone is different, obviously, with the size of your hand. But if one thing they'll do is, you know, you'll prepare for how many fingers are for centimeters for you. So whenever you're assessing things like that. I'm sharing the screen now. Okay, posterior and anterior, right there, posterior closer to the pelvis. Softening, firm, longer to open up, softer is closer. Then we have our Bishop score, which brings all of this together. This is a score of effacement, dilation, P and A, softening, posterior, closed, thick, high. This is all zeros, not ready to have a baby. The anterior, opened, soft, head down equals ripe, baby is ready. So the higher the Bishop score, the more ready the laboring process is going along. We have passenger. It's important to know these terms. We have fetal lie. The spine of the baby in relation to the spine of the mother. You want these spines to be parallel, okay? Attitude, how the head is positioned. Normal attitude is flexion of the neck, arms and legs. This allows our head to slide down the pelvis and out of the vagina. The presentation, the presenting part is always what you see first. The most common one is cephalic, also our head, the back of the head actually. With position, the relationship of the presenting part to the maternal pelvis. Engagement, when the largest diameter of the presenting part reaches the pelvis inlet and can be detected by vaginal examination. And then we also have station, the relationship of the presenting part to the ischial spine. And it's important, guys. The numbers are, what I always did was +4 on the floor. So if the station is +4, the baby's out of the vagina. And then we also have estimated fetal weight. All right, we have a fetal lie here. And I'll try to show video. I have these little babies here. All right, so typically you always want them to be parallel. Okay, so if we have a breech, I'll show it more on there. I actually included pictures as well, but that is whenever the legs are coming first or our buttocks are first, okay? Transverse is laterally across the uterus. I have a picture in there, but also if you're wondering why this is the most high risk, this is because our baby is not going to fit into the birth canal. The uterus will be contracting. Something is going to give, and after a while, you know, the uterus is softer, so that uterus will burst first. Okay, and oblique will be diagonal. Okay. We have our fetal attitude, how the head is positioned. Normal attitude is flexion of the neck, arms and legs, allowing the head to slide down the pelvis and out of the vagina. The worst is to have a partial extension. Why? This is because partial extension actually kind of has the biggest diameter of the head, okay? We have 3, we have flexion, partial extension, and full extension. The picture I have right here is the full flexion. You'll notice the head is tucked in. Whenever it comes to things like, I know there's one like called like the military, things like that, but just pull it up in the book so you can have like a pretty good picture of what it is. Note that the smallest diameter presents towards the pelvis. Yes. All right, next we have fetal presentation. The fetal part entering the pelvis first. Most common, of course, is head first. We have the frank breech, which is the butt first. We have the syncopate, the head partially flexed. We have a shoulder first. That could go aside with things like shoulder dystocia, things like that, but that's kind of not on this exam for that, knowing the problems of shoulder first, okay? With the brow, head partially flexed with brow presenting. We have the footling breech. This can be single, 1 foot, or double, both feet. And then we have the full breech. Thighs are flexed on the abdomen and legs on the thighs. One thing I always thought about, and I'll show you pictures as well. Let's keep going. We have the types of breech presentations here. A right here is a frank breech. That's kind of where the feet are up towards the head. With the complete breech, I always thought about it as if it's complete is, they're almost like kicking against the wall in front of them. Okay. And the single footling, we have 1 foot that's presenting, and 1 foot is kind of in a knee position. And then the double footling is 2 feet down, okay? We have the fetal position, the relationship of the fetal presenting part to maternal pelvis. A 3-letter notation is used to describe this fetal position. I really encourage you guys to read your textbook for this for more information, because it can be a little confusing just based off of this stuff. The first letters tells us which side of the maternal pelvis the presenting part is toward. We have right and we have left. The second letter is the landmark of the fetal presenting part. We have OMA. Occiput is more for a vertex presentation. Other side, we're having the lower back of the head. Mentum is the guiding port for a face presentation. I put in the chin. That's what I thought about it. Acromion process, where this is the guiding port for a shoulder presentation. And then this is all really important because on our exam 2 guys, for the prep sheet, we're actually going to have like a little diagram where you're going to label kind of all of what these things can do. Okay. Third letter is the rotation of the landmark of the presenting part to the front, back, or side of the pelvis. And then most common is ours, ROA or LOA. For that third letter, for a transverse, if the presenting part is directed to the side of the maternal pelvis, the fetal presentation is designated as transverse. And for that third letter, if it's going to the mother's back, it would be posterior. If it's going towards the front, it would be anterior, okay? This is kind of a drawing, not a drawing, but this is pulled from a book to kind of imagine where the momentum is, the occiput, and the vertex is, okay? And then we have a chart that we've added in as well. Ali had found this and I thought it was really helpful, but pay attention. Do you see how it says positions in vertex presentation, positions in face presentation? This is kind of a lot of information. Some of these we don't really talk about, but it's kind of cool how this already organizes it for you for which the presenting part is going to be, okay? And this would help with seeing breech, vertex, things like that, okay? We have some pictures here. Alrighty, if you want to just, take the slide and compare it to these so you can kind of get a visual, that's what I did. And of course we have fetal station. And I'm gonna alrighty. As we're going with this, so the higher they are on the numbers, I'm sorry, the more negative the number is, the higher they are above the ischial spine. Once we get down to the negative numbers, that's whenever it's already passed, okay? That's also like kind of where we're getting to like engagement, things like that, but essentially it's pretty easy. This is one of the easier ones to memorize. +4 on the floor. It's past that already. Okay. All right, powers. Important to know these terms. I guarantee you this will be tested on this slide right here. The time in the seconds or minutes measured from the beginning of one contraction to the beginning of the next. We have these terms here. Increment, the building up phase. The acme is the peak. We have the decrement, the letting up phase, and then outer. That is the resting phase that actually provides oxygenation, because during these contractions, the oxygen is really not being distributed that well. So that relaxation phase is very important on getting oxygenation to our mother and baby. Intensity, the strength of the contraction at the acme can be palpated as mild, moderate, or strong, or detected by an external fetal monitor or internally in mmHg, millimeters mercury. Pattern, resting tone, uterine perfusion, and the difference between voluntary pushing and involuntary pushing. On voluntary, our mom is doing the work by pushing. On involuntary, our baby's doing the work. This is kind of a chart here. This is from the textbook, just a little more on it, okay? But we have the acme, that's going to be the peak of intensity. We have the increment where it's building up, and then it's going to be resting as well. Alrighty, and it's important to know that the frequency is from the beginning of one till the next, and the duration is from the beginning to the end of the contraction, okay? You'll see the arrows right there. Intensity is from the acme, that's it. We have psyche, the comfort, fear, pain, excitement, anxiety. How would this affect the labor? Trust, we want the patient to feel like her and her baby are a priority, your role is to make this happen. Resistance, if they have a perceived loss of control, feeling ill-prepared, anxiety is very common. Alrighty, control, the bodies can have a hard time being out of control. Readiness, the lack of knowledge and preparation can negatively affect psyche, altered thought processes, communication barriers, etc. Physiological manifestations, if they have an increased blood pressure, increased heart rate, increased respiration rate, these can harm our baby. We also have our hormonal factors, prostaglandins, oxytocin, stress hormones. Prostaglandins will stimulate our GI and our uterus. And then oxytocin, pitocin, same thing, induce contractions, okay? We have our onset of labor. Before labor actually occurs, we have what's called nesting, which is really cool. Our mothers instinctively will prepare for the baby. Even if it's already clean, they're gonna clean the entire house, do the laundry, get the nursery ready, things like that. It's kind of just an instinct. True labor and false labor, you need to know the difference between these two. I would just say write it out, and honestly, once you kind of do it a lot, it'll make a lot more sense. One thing you could do on the PowerPoint I gave you is the words that distinct between the two, maybe bold those or highlight those. So right away, true is at regular intervals, false is at irregular intervals. True, these shorten, and false, these things always remain long. Keep going is true still. True, the intensity increases, the pain is more in the back. By walking, it actually intensifies. And then, of course, they're going to start showing after a while with really that cervical change. With false labor, this is more the practice contractions. We have the intensity always remains the same. The pain is more in the abdomen. Walking has no effect and actually often provides relief. And then, of course, they're having no cervical changes, okay? I remember reading in the book, the timing of your contractions, like when to come in and things like that. It's really neat. Okay, I actually provided a really good chart in this PowerPoint as well, but this is going to be, this is kind of what I used before I had found that in the book. We have the stages of labor, okay? They are kind of going off of the different centimeters dilated and then kind of how they're feeling. I would say you need to know the timing of it too. That's why I provided it on the back of the PowerPoint. But we have the 4 stages of labor, but within stage 1, we have 3 different kind of phases, rather. We have the early latent phase, which is from 0 to 3 centimeters, often called 0 to 4 now. It's kind of changing a little bit. We have active, we have 4 to 7 or 5 to 6. Transition 8 to 10. Okay, so whenever we're 8 to 10, it's they're getting ready for delivery. Okay, 0 to 3, how would they kind of be acting? Things like that. Okay, on the first stage of stage 1, so the early latent stage, these contractions I think were occurring every 3 to 30 minutes, lasting around 20 to 40 seconds. With the active stage, it's every 2 to 5 minutes, lasting 40 to 60 seconds. And then the transition phase is every 1.5 to 2 minutes, lasting 60 to 90 seconds. So right away, what I kind of did to memorize that was knowing that the seconds that these contractions are occurring are actually becoming longer. So it goes 20 to 40, 40 to 60, 60 to 90. And then how often they're occurring is actually decreasing. Okay, so it starts off 3 to 30, every 3 to 30 minutes, then it's every 2 to 5 minutes, and then it's 1.5 minutes till 2 minutes. Okay, let's go to stage 2. Stage 2 is from 10 centimeters dilated to the delivery of the baby. This can last 2 to 3 hours. Head is coming down. Okay, once that baby is delivered, now the placenta is going. This could be fast. This could be really long. Okay, if at all we have any part of our placenta kind of attached in there, that is call for lots of bleeding. Okay, now we're going into stage 4. We have the involution of the uterus. This is that first couple of hours. It's important once the placenta is out to rub the fundus. You want the fundus to be firm and to stop bleeding if there is any, to prevent postpartum hemorrhage. Okay. Postpartum hemorrhage is actual emergency, and that can be, if not taken care of correctly, fatal. First couple of hours, first hour, check the fundus and vital signs every 15 minutes. Second hour, check every 30 minutes. Okay. We have the assessment tools used during labor. We have the EFM. This provides computer-assisted auditory and visual assessments of the fetal heart rate and uterine contractions. That in kind of today's world, you're always going to see that on there. Sometimes with natural birth, things like that, sometimes they won't have it. And you'll also be very surprised to see, sometimes in clinical, you'll see this. Sometimes people can give birth in the elevator or something like that, and they don't even have these assessment tools hooked up. So, the birth can still occur. External monitoring, ultrasound transducer plays on the fetal back, detects movement of the fetal heart, fetal or maternal movement, and maternal obesity may interfere with these readings. Okay. So when it comes to the external monitor, the position that they are in the bed can kind of also affect this. We have the internal fetal scalp electrode. This is inserted through the cervix and attached to the epidermis of the presenting part. Okay. Provides a direct ECG of the fetal heart, but there are criteria for this. They have to be at least 2 centimeters dilated with a rupture of membranes. We have the IUPC. This is a wire with pressure gauge on inserted through the cervix and past the presenting part into the amniotic fluid in the uterus. The cervix must be 2 centimeters dilated with rupture of membranes before this can be inserted. So it's important with infection. If at all we have a very serious infection going on, maybe it's like an STI or something like that, we might not be doing some of these IUPCs, things like that. Baseline fetal heart rate, the average heart rate between contractions, know these ranges. So normal is 110 to 160. Bradycardia is less than 110, and then tachycardia is more than 160. And then to assess if we even have a rupture of membranes, we're going to have nitrazine paper. So this is a yellow paper that turns blue when it comes into contact with the amniotic fluid. Can help determine the rupture of membranes. We have the Leopold's maneuver. The doctor will place 2 hands on the uterus to determine the position and possibly size of the fetus. And then on admission, we're going to be having a CVC, urine analysis, maternal vital signs, status of membranes, fetal status. Once we have the rupture membranes, what do we need to monitor for? Infection. Okay, infection, the longer of the rupture membranes, the higher the risk of infection that can happen. A sign would be fetal tachycardia and fever, okay? Which would be not good. We have Vil Chop here. This, you're gonna have to write all, I would say write all of this down, make it into your little notes. It will really help a lot. And you will be tested on this, okay? Whether it be, seeing this on a fetal heart rate monitor, or you're just, just describing the condition, okay? So we have variable decels. This can happen with or without contractions. They'll have a W or a V shape, abrupt, sharp, and sudden. As long as the baby can be recovered, this is not concerning. Position better or IV fluids are needed to get, if not getting better. I didn't really say that, but with Vil Chop, the reason we always say that is because the V goes with the C, the E goes with the H, okay? So for variable decels, what is causing this? It's cord compression. 15 by 15, but less than 2 minutes in duration, abrupt with fetal insult, not related to uterine contractions, okay? When it says 15 by 15, I think that is, it's the number of beats the fetal heart rate has changed. And it has to change for about 15 seconds, okay? So it's going up 15 or down 15 for about 13 seconds. We have early decels. This is not a bad thing if the labor is progressing, but this is due by head compression, the vagus nerve stimulation from head compression. This is often uniform in shape. This mirrors the shape of the uterine contractions. Symmetric gradual decrease, reassuring as long as labor is progressing, just prior or early in uterine contractions. We have accelerations. This is always okay. We have an increase in the fetal heart rate. Must be 15 by 15. The general associated with a CNS stimulation. This is often fine, so no interventions are required, okay? Late decels, you want to turn her on her side to increase the blood flow to the placenta. You want to give them IV fluids, oxygen, turn off the Pitocin, that's very important, and then do a late return to baseline. And this is due by placental insufficiency, kind of a decreased blood flow, or oxygen is transferred to the uterus. The shape reflects the uterine contractions. This is late or after uterine contractions. And then this is non-reassuring. Okay, so this indicates fetal hypoxia and acidemia. We have our variable decels. Just kind of a picture of this. So as you can see, we have the shape of the contraction here, and then it's decreasing and it's kind of late, okay? Not late, but yes. We have the early decels. So you can see that it's kind of mirroring, but it's also a little before of the acme of our contractions. We have the accelerations. This one's the easiest one. It just accelerates. And then late decels. So the acme is here, but the onset of the decel is often behind or later than our contractions, okay? Going into fetal heart rate baseline changes, we have the average of the fetal heart rate over a 10-minute period rounded to increments of 5 beats per minute. The baseline variability indicates the fetal cardiac and neural function, their well-being. So we have absent, we have no range, which is concerning because the heart rate isn't changing at all. We have minimal, which is changing 5 beats per minute or less. We have the good one, which is moderate, 6 to 25 beats per minute. And then we have marked where if it's greater than 25 beats per minute, their heart rate should be from around 110 to 160. And if they're preterm, we have a higher heart rate again. Assessing the fetal well-being, we have contractions, we have fetal heart tones, we have fetal scalp monitoring, looking at their pH of the baby's blood, increased risk for infection. The fetal scalp stimulation where they kind of go in and it's like, hi, how are you? If nervous system is intact, the baby should accelerate. Okay. We have the fetal fright testing, VAST, startling the baby, increasing the fetal heart rate, and causing an acceleration. Then we have the cord blood gas analysis. This can't be done until the baby is out, okay? So what they'll kind of do is they'll actually take it from the umbilical cord, and I think I've seen this. We have the cardinal movements. We have a descent whenever the head enters the pelvis. This is caused by the pressure of amniotic fluid, pressure of the fundus on breech of the fetus, abdominal contractions, the extension and straightening of the fetal body. So they're kind of descending into the canal, okay? We have the flexion. The fetal head descends and meets resistance from the soft tissues of the pelvis and muscles of the pelvic floor and cervix to the fetal chin, flexes downward onto the chest. And one thing I'd recommend, this is a lot of definitions, but I would say just in the textbook, they actually kind of have a picture of each of these, so it kind of makes a little more sense. We have internal rotation. The occiput rotates from the left to the right in order to fit the diameter of the pelvic cavity. We have extension, where the fetal head extends as it passes through the pelvis. Occiput, brow, and face emerge from the vagina. We have restitution. The shoulders of the infant enter the pelvis obliquely after internal rotation, kind of like a twisted neck. The neck untwists once the head emerges and turning the head to one side. Then we have external rotation. The shoulders rotate to the anterior posterior position in the pelvis. The head is turning farther to one side. With expulsion, this is external rotation, the pushing from the mom, the lateral flexion of the head and shoulder. Anterior shoulder is born before the posterior shoulder body follows. I don't think you'd be tested on like the nitty gritty of this stuff, but with the phases of it, really just kind of know the order, things like that. Okay. And again, if you're looking at a picture, this kind of helps a lot, but we have kind of a picture here, but it doesn't really do justice compared to what I've seen in the textbook. I just didn't want to put so many pictures in here. Okay. But as you can see with the rotation of the head, I mean, we have the internal rotation and the external rotation, things like that, kind of what occurs. Okay. All right, baby's out, now what? It's important to warm, dry, and stimulate. We do an ABGAR test. And guys, this is, once you first learn about the ABGAR, this will be all throughout OB, but also even in the peds, okay? We have appearance, pulse, grimace, activity, and respirations. These scores range from 0 to 10, with 10 being the best. I'm not going to say it's rare to have a 10, but usually they're going to be a 9. So you're going to go to the hospital and you'll be in the nursery and they'll say, ABGAR is 9 and 9. You know, just because they didn't get a 10 doesn't mean it's a bad thing. Because that's kind of just acrocyanosis. But the baby should go on mom's chest, facilitating bonding between mom and baby. Exemption is if they have, you know, like a 6 ABGAR and they need resuscitation. Okay. You know, we're going to warm, dry, and stimulate them. They're going to get a band that's going to match the mothers, okay, and the fathers. Once the placenta is delivered, we need to massage the fundus. We want to make sure that we're, you know, not going to be bleeding, things like that. Okay, going on to newborn safety. I already kind of said this, but identification, the baby must be identified before going to the nursery, before separated from mom. So we're going to give them a wristband. Well, mother's going to get a wristband. Baby's going to get kind of like a anklet. We have warmth. We're going to, you know, make sure they're warm. They're going to have caps. They're going to be on mom's chest. Skin to skin is very important here. We have the airway, positioning the baby with the face down or side lying on mom's chest. We're going to stimulate them if needed. Nutrition, you determine how mom plans. Comfort, bonding, attachment, skin to skin or kangaroo care. Inoculation, if we're going to do vaccines before discharge, or try to at least, but we're going to do infection prevention. We're going to be doing hygiene teaching for mom. Roll out the major defects as well. All right, we're going with the ABGAR now. Again, 0 to 10, 10 being the best. The how this kind of goes is with heart rate, if it's absent, 0, if it's less than 100, 1, if it's greater than 100, 2, with respirations, absent or slow, irregular, or good breathing, with crying. And with crying, guys, that usually is an indication of a very healthy baby, because their heart rate's going to be up, they're going to be, very jittery, things like that. So that'd be good. With muscle tone, if they're flaccid, they're still, if they're kind of doing flexion of their extremities, or if they're just squiggling, doing that active movement of all the extremities. We have the reflex response. We have absent. We have the which would be 0. We have a grimace. Noticeable facial movement would be a 1. And if they're crying, this would be a 2. A vigorous cry, cough, sneezes, pulls away when touched. Then skin color, pale or blue, would be a 0. 1 is a pink body, blue extremity. That's called acrocyanosis. And then 2 would be a pink body and everything's pink. Alrighty, and here is that last slide that I was talking about. I would say write all this down. So one, you can put your little highlighting things, kind of make it a little more important to you. But otherwise, I think personally, just writing stuff down sometimes helps you memorize it than just looking at it on the screen. Okay. And yeah, that's pretty much it for today's session. If you would please, if you haven't done it, please do the QR code so we can kind of keep attendance. Not attendance, but to kind of keep a head count of how helpful this is being. And I really think that for those that have came for exam 1, I heard the exam scores really well. So if at all that this helped, thank you for kind of doing this with me. It was really fun. Have a great week.